Welcome. This is Dr. Barry Bartee, and today we will be focusing on the use of titanium reinforced dense PTFE for immediate socket reconstruction. And this is our patient, a 55-year-old lady who presents with external resorption of the maxillary left central incisor. The crown has been temporarily cemented, and the plan is to extract the tooth and preserve as much bone and soft tissue as possible. And you can see erythema around the crown margins indicating inflammation. So we begin by probing and bone mapping the socket and taking a number 15C blade and make an intrasulcular incision. And the incision is designed to allow the interdental papilla to remain intact if possible. And then we begin using a microperiosteal elevator to luxate the root and perform some very minimal flap elevation. This is the power tome instrument, which is employs a very thin periotome tip, which can be used to sever the periodontal ligament from the very thin buccal and palatal plate. The periosteal elevator is then used to luxate the root. And you can see considerable movement at this point, and then a number 1 forceps is used to remove the root. It is very important at this stage to remove all soft tissue remnants, and in particular the soft tissue associated with the resorption cavity on the root. And we do this with curettes and also with Adson forceps, just very carefully separating the tissue from the surrounding flap and bone. Now this is the periosteal elevator again, used very carefully to elevate a flap. In the interproximal zone, we just want to expose the crest for placement of the membrane, and then we want to advance the elevator 3 to 5 millimeters beyond the socket margins on the facial and palatal aspect of the socket to create a space for the membrane. And this is using a larger instrument such as a round curette or the large end of a periosteal elevator to create a little more space. And then once the space is created, we normally place the graft material, and this is a combination of demineralized and mineralized bone allograft, and in this case combined with platelet concentrate, but you can use venous blood or sterile saline as well. And so we're placing this material and evenly distributing it through the socket, but you do want to avoid very dense compaction of the graft, just nice, soft, even pressure. And then once the socket is completely filled, we begin trimming the CYTOPLAST membrane. The membrane is held with talc-free gloves and then trimmed carefully with surgical scissors, and the goal is to remove any sharp corners or sharp edges, and to trim the membrane so that approximately 1 millimeter remains between the adjacent tooth roots and the membrane edge. And you can see pre-curving the membrane over a round instrument handle does help facilitate placement. And we begin by placing it in the palatal subperiosteal space first, and then into the facial subperiosteal space, and then work the membrane into the interproximal spaces. And again, you'll note the interdental tissue is intact here. So the goal is for the membrane to rest on the interproximal bone if possible. And if the bone is extremely thin, you can leave it resting on graft material. But ideally, we would be sealing the socket 360 degrees around the circumference of the socket. The space between the root and the membrane allows for blood supply to develop quickly to the flap, and this does help prevent recession of soft tissue or even loss of the papilla entirely. So we very carefully irrigate with sterile saline here to eliminate any possibility of a graft particle being trapped between the flap and the membrane surface. We're closing with CYTOPLAST CS5 PTFE monofilament suture. And initially you saw the curette placed between the flap and the membrane, and this is important to prevent puncturing the membrane or creating a hole in it, which would allow bacterial migration through the membrane and could result in infection. So you need to take great care to prevent any damage to the membrane surface at this point. So we usually accomplish this by placing the curette under the flap and then the needle through the tissue into the curette surface. This is a modified crisscross suture design, and so my goal is to achieve good adaptation of the soft tissue to the membrane surface. We're trying to create a seal, but you also want to avoid over-compressing the flap or any other maneuver that would compromise the blood supply to the flap. Now our suture is tied using a double throw and then 2 or sometimes 3 single throws in opposite directions so that the suture is locked in place. But we do take care to avoid over-tightening these sutures. And that would be indicated by excessive blanching of the tissue or cutting of the tissue with this suture. And then once again, the socket will be irrigated with sterile saline, checked for any stray graft particles. And then in this case, we did apply platelet-rich plasma again to the outside of the wound. And then trying in the prosthesis. We prefer a tooth-borne temporary prosthesis if possible. If you do use a tissue-borne device like this, it's important to check and ensure that there's no compression of the tissue or any part of the device that would compromise blood flow to the flaps. Also, we're checking the occlusion to ensure that there's no movement and adjust the device appropriately. And you can see in this periapical radiograph, the socket is filled with bone graft material. The titanium membrane is in place. This is at 2 weeks of placement with the membrane left intentionally exposed. The indications for the CYTOPLAST titanium reinforced membranes are when you have larger defects or missing buccal or lingual plate, and just where additional stability is desired. The titanium reinforcement allows us to maximize graft volume. We can pre-curve the device, facilitating placement, and the requirement for primary closure because of the design of the device is eliminated.